Hello everyone, welcome to this roundtable discussion regarding alcohol-related brain damage. My name is Ruth Northway and I'm going to be chairing this discussion. I'm Professor of Learning Disability Nursing at the University of South Wales and here in my capacity as Faculty Head of Research. Before we start on the questions, I'm going to go around the panel and ask if they can briefly introduce themselves. So if I can hand over to Bev.
Hi Ruth, yes, I'm Bev John. I'm Professor of Addictions at the University of South Wales and I co-lead the Addictions Research Group.
Thanks Bev. Julia?
Hi, I'm Julia Lewis. I'm a consultant addiction psychiatrist with the Aneurin Bevan University Health Board and a visiting professor at the University of South Wales.
Thank you. Andrew?
I'm Andrew Meisel, Director for Wales at the charity Alcohol Change UK, and I've been working in the substance misuse field probably for the last 10 or 12 years.
Thank you, Andrew. Gareth?
Thanks, Ruth. I'm Gareth Roderick Davis. I'm Professor of Psychology at the University of South Wales, and I co-lead the Addictions Research Group with Bev.
Thanks, Gareth. Raman?
Hi, I'm Raman Sakhuja. I'm a consultant psychiatrist in the board and also a visiting professor with the University of South Wales and have a special interest in neuropsychiatry, specifically brain injuries, traumatic or non-traumatic, and their consequences.
Thanks, everyone. Just by way of setting the scene, I just wonder if perhaps, first of all, Gareth, can you tell us a little bit about what alcohol-related brain damage is?
Alcohol-related brain damage is it's a complex set of conditions which involve structural and functional changes to the brain as a consequence of long-term excessive alcohol use. And it can be thought of as a spectrum of disorders, starting at the more mild end with mild cognitive problems, progressing through to more severe problems such as alcohol-related dementia, and then also other problems which are not necessarily related to the direct neurotoxic effects of alcohol itself, but more related to things like vitamin deficiencies. So there are disorders such as pellagra and also Korsakoff syndrome, which are far more severe disorders and can exhibit as severe cognitive problems, severe memory problems, and such as confabulation, for example, where an individual may have confused memories where they fill the gap with almost created or imaginary memories. So it's thought of as a spectrum of conditions related to long-term and excessive alcohol consumption.
Okay. One of the words that you use there, which I think people probably might want a bit of clarification about, is what do we mean by this term excessive? Because I think probably people judge that in different ways. Bev, I wonder whether you could say a little bit about that.
Well, it's it's a very important point. So as most people probably know, the public health guidance on what are safe levels of drinking is up to 14 units a week, and that is spread over the week with alcohol-free days during the week. The recent statistics in Wales show that around 18% of people self-reported drinking more than that, and people who drink a lot or drink more than the guidance consume around 2/3, so around 70% of the alcohol that is consumed in Wales. So the sort of, you can immediately see the sort of it clusters a little bit above that. In terms of alcohol-related brain damage, what research suggests is that to be sort of in the at-risk group, if you like, so to be consuming alcohol at levels that put you at risk of developing alcohol-related brain damage, tends to be around the levels of about 35, approximately 35 units per week. And that, we do talk about chronic alcohol consumption, so that's over a sustained period of time, if you like. So you may say, I don't know, 5 years or more. I think an important point when we think about units and what constitutes units of alcohol is that it's actually often less than people think. So 35 units of alcohol a week would be approximately, you know, give or take 15 pints of beer or lager and 3.5 bottles of wine. So when you think about it in those terms, this is not, so, you know, we're not talking about something that is unique to sort of people that some people would stereotype as very, very high drinkers. I think that's an important, you know, consideration for everybody, really.
It's interesting there, because you talked about people being at risk of this, and I'm just wondering whether there's any particular groups of people who might be deemed to be at risk. I'm just wondering, Andrew, whether you would perhaps be able to comment on that.
I think historically we always assumed that alcohol-related brain damage or Wernicke-Korsakoff's, similar conditions like this were the sort of thing you'd expect to find in street drinkers, probably the sort of the stereotype that people could imagine, an old man with a grubby beard carrying his life around in a shopping trolley. And that cohort of drinkers, of heavy street drinkers, who are often very undernourished and physiologically alcohol dependent, and alcohol is often their main source of energy as well. They're obviously a very high risk group, but interestingly, what we've seen from a number of studies, particularly from Scotland, I think, is that although you might expect to find the bulk of cases amongst older men still, we are seeing them in younger people. And when I say younger, I don't mean very young, like sort of teenagers and 20s, more sort of 40s and 50s. And also seeing them really across the social spectrum amongst people who might consider themselves to be respectable professionals, for want of a better word. So although a lot of the focus will be on the very sort of obviously vulnerable drinkers, as with all drinking issues, it certainly doesn't help to stereotype too much.
I don't know whether
Sorry, can I just comment there as well? You know, I just picked up what Andrew and Bev were saying. I think one other group that we sometimes forget is the pregnant women. And we talk about ARBD in its, you know, although it is an umbrella term, most people will still think about ARBD only in terms of the Wernicke's, and all the other rest of the syndromes seem to sort of be ignored, but they're not at the forefront. So, you know, the brain injuries, for example, traumatic ones, which are associated with alcohol, that's one. And pregnancy, as I was talking earlier, this, you know, there is no safe limit in pregnancy. And there have been time and time over and over, needs to be emphasized, because now there's so many papers coming out in research which clearly tell us the incidence of autism, ADHD, and neurodevelopmental problems that, you know, the children start developing in who are exposed to alcohol in utero. So that's something to just bear in mind as well.
Yeah, I don't know whether Julia, whether you wanted to come in from a clinical perspective as well on that.
Yeah, I mean, we are seeing younger and younger people present with it. I think my youngest was in the mid-30s, whereas the majority, I would say, in the sort of 50 to 60 age range. We do know from research that women tend to develop it earlier than men do. So there's something particularly vulnerable about the female brain. And also, if you are of a higher intellectual capacity to start off with, it's almost as if you've got more brain reserve to lose before people start to notice that there are symptoms. So that's becoming evident as well. And although we talk about the conditions, the neurocognitive conditions that are linked to alcohol, you can have more than one neurocognitive condition. So that some people can have Alzheimer's as well because they've got a family history of Alzheimer's, or you know other sorts of things. So very often when we do in people with alcohol-related brain damage, we find other things as well. So obviously those people are more vulnerable then to the effects of alcohol.
And I think that is, Julia, what you said is critical, because you know, when you are seeing these patients and how these services are designed are such that they seem to be sort of mutually exclusive. So if someone has an alcohol-related brain damage, almost feels as if they can't have Alzheimer's or any other degenerative condition, and it's just like, oh, it's alcohol, over to CD80. Only if it is dementia, then we'll be interested, and we deal with it all the time.
Yeah, I mean, this is
box.
Yeah, I mean, this is one of important issues, and one of the reasons why I would use the word complex when RBD was, and you know, the very issues that Andrew, Julia, and Raman have referred to make it difficult to even sort of pinpoint precisely what sort of prevalence we're talking about here, because there's a lot of confusion around what counts as ARBD, what an ARB diagnosis is, and also the complexities of other disorders. So, you know, in our own research, we've tried to identify what the prevalence of the disorder is, but we've really had to piece it together from other pieces of information by directly talking to services and service providers who come into contact with people at risk. We've had to try and establish what sort of labels people are putting on the conditions that they're observing and whether that fits the ARBD definition. So part of what we're talking about today is the need to raise the awareness more generally to the condition, so that people can start to recognise that what they're perhaps labelling as something else fits under this umbrella definition.
It sounds as if, I mean, obviously it's a very diverse group of people potentially that this particular label would apply to. But what would be obviously in common is the fact that everybody's drinking and drinking excessively over a long period of time. So going back to the starting points, I suppose, why do you think people turn to drink in the first place? And I mean, is it like other addictions? Does it progress in the same way? I don't know whether either Julia or Raman want to comment on that.
I mean, alcohol misuse is multifaceted. It's a legal substance, so a lot of us have tried it, and we will know that when you take it, you get a kind of a relaxation effect. There is an immediate effect to taking alcohol. So if you're someone who is quite anxious or who has underlying horrible suppressed, or just, you know, struggles to deal with daily life, you get introduced to alcohol, which is virtually inevitable, and you find something that sorts it out for you and sorts it out like that. The problem is that the alcohol does a couple of things then. First of all, it stops working, so you try and drink more. So when you don't drink it, you get an effect that is actually the original symptoms in the first place, but magnified, so you keep drinking. And also, you know, as I say, the great difficulty of it is that it hijacks this natural system that we have in the brain for motivating us to do the things that we need to do to survive. So there's a set of pathways in your brain that make sure you eat and you drink and you procreate and you do all those things that the species needs to survive. And alcohol hijacks it. And alcohol says, now I'm going to make me the thing you need to survive. And that is an incredibly powerful driving force for people.
Yeah, yeah.
Which I think, you know, as Julia has very, very eloquently put it, I was thinking as she was talking of a traffic light system. You know, so there is a red button in the brain, which is, you know, the front part of the brain, in technical terms, the prefrontal cortex, which has that stop button. So you and me, maybe after having a few drinks, know when to stop. Whereas in an addicted brain, when it has become a chronic brain disorder, that button is no longer operational. And it's just go, go, go. The green light is just on. And it's sometimes easier for people to understand that if they know that this red button is not there, it's not a matter of choice for those individuals, which very often people think, oh, why can't he or she just stop drinking? Well, if it was that easy, then we will not be sitting around on this table.
Yeah, and from what you're saying there, it sounds as if it could be quite difficult for that process going on in themselves, and you know, so therefore, how do how do people admit to themselves and maybe to others that they've got a problem here? I don't know that perhaps Andrew, whether you want to start on this one and other people come in.
It's tremendously difficult. I mean, I remember someone working in alcohol services in my local area saying that it'd be easier to get planning permission for a pub than it would for an alcohol treatment centre, and that sort of really highlights the sort of twisted logic of our society sometimes, and that we're generally quite jocular. I think the British in particular are quite fond of joking about alcohol in the way that perhaps other nations don't. But then when alcohol becomes a problem, we're not too sure what to do with it. We think it's all a bit embarrassing, and you might want to perhaps get that person out the way somewhere, or somehow minimize the problem that they're causing to themselves and others. And I think it does make it very difficult. And I always say, whenever I'm visiting people in recovery in normal times, I normally spend one morning a week with people in recovery from alcohol, and I always say to them, look, people probably look down on you because you're a bunch of drinkers and drug users and things, but you're the people who actually stopped to think about what you were doing. You're the people who put your hand up and said, oh, do you know what, I think my life is on the skids and I'm going to do something about it. Whereas the general society outside that probably thinks it's doing very nicely has not had that difficult moment. And I always say to them, I think you've been very brave. You know, the thing you've done, I don't know whether I could do it. So it is definitely, it is a difficult thing to do, to admit a problem.
I think that point of stigma is really...
Sorry, can I just come into what Andrew was saying there? I think it also comes back to the, what we were talking about at the beginning in terms of the stereotype of who is a problem drinker, because I mean, I've worked over the years in, with psychological interventions with people who drink, and it's so interesting, the barriers that the psychological defense barriers that we put up in terms of what is a problem drinker. And you say, how do you, admit to yourself or admit to others? But it's always the other person, not us, So for example, I drink expensive bottles of wine. I may drink 3 of them a night, but I can't possibly have a drink problem or be dependent or an alcoholic. Expensive bottles justify those things. It's because it's so, I think because it's so embedded in our culture. I remember many years ago, I think it was in the 1990s, the Royal College of Psychiatrists referred to alcohol as our favorite drug, and it sort of stands, doesn't it? I mean, it's a very simple definition, but I think it stands, and it is very much about, we bat it out to the other people have problems with alcohol, not us, and that's a big barrier to getting help, I think.
And just briefly picking up on the stigma point that Andrew raised, it's almost as if within British society there's more of a stigma attached to not being a drinker than there is to being a drinker. That, if you're somebody who wants to stop drinking or wants to start drinking non-alcoholic versions of drink, that there's almost a reluctance to admit this even to your own peer group because of the stigma attached with not being a drinker.
Mm. So stigma almost and peer pressure can affect you either way in that situation, both in terms of starting but also in terms of stopping. Yeah. Okay.
Yeah. I would say, we may come on to this in a bit, but I would say certainly in terms of alcohol-related brain damage, you're really talking about stigma times 2 there, in that you've got a condition that people might regard as being self-inflicted. Someone has brought this on themselves by not desisting with their drinking, even though, as Raman's just said, they may well have gone well beyond the point where they were capable of stopping. And then the consequences of this damage to the brain is that their behaviour then becomes tremendously inappropriate, unpredictable, objectionable, rude, unexpectedly sexual, all the sort of things that would really make them quite difficult to deal with. I think it's one of the reasons that people working on this condition get so passionate about it, because the client group, for want of a better word, the patient, is often so excluded and so as regarded as being such low status by society. But as I'm sure we'll come on to, the condition is eminently treatable, and people can recover themselves, and all that strange and objectionable behaviour is not really themselves at all. It's the condition at work.
Mm. Yeah, I mean, I think obviously you sort of said there about it is something where it is possible to intervene and to change, and that's. I'm just thinking, you know, maybe if we can move on to think about how you would treat people with ARBD once people have got to that stage of being able to recognise this issue which they have themselves. How would you then go about sort of treating? Perhaps I could start with Raman.
Yes, I think before we go down to the treatment, I think one of the key things for me as a clinician is recognition of the condition and the various sort of forms it comes in, you see. So once we are able to understand that, you know, when you're going to see a person with alcohol problems, number one, we need to keep in mind that, okay, a person with alcohol may have alcohol liver disease, but equally, as a consequence, may have an encephalopathy secondary to that, or a direct alcohol-related brain complication as well, with its different sort of facets. Once we recognize that, I think it is then starts becoming important to have a treatment that covers the multiple dimensions, because, you know, with ARBD, we're not just talking abstinence. That is the key, absolute key, because once you remove the offending agent, you're getting in the right direction. But then they have so many other nutritional problems, you know, physical comorbidities, mental health problems, specifically stress, anxiety, you know, other depressive disorders, and a lot. So it is not just one. In my view, the treatment has to take into account a comprehensive assessment plan and work with them, not short term, but as a multidisciplinary approach for a long period of time. Where then the legal dimensions start coming up as well, in terms of, you know, people with cognitive problems. As I'm speaking, actually, I'm thinking of a patient that I'm dealing with currently in the clinic, where they're cognitively impaired, and we are struggling to actually on the cusp of whether we say this person has the capacity to make decisions for detox or not. And if we say they don't have the capacity, then it opens up a big armory of other machinery, the legislation and the care packages. And also, I think there's no one single answer to the treatment. It is complex as the condition itself.
Yeah, so it's complex and it has to be over a long period of time. And you're saying obviously putting in lots of different elements. So anything you wanted to add to that, Julia?
Yeah, I mean, I think the thing that we need to remember about ARBD, in contrast to the conditions that it mimics, which are the dementias, is that if you can assist someone to maintain abstinence from alcohol and, as Raman says, take a good diet, which might need supplementation with this particular vitamin called thiamine. If you can do that, then up to 75% of them show some degree of improvement. The remaining 25% won't deteriorate. So it's not like, you know, Alzheimer's, that, okay, we can give drugs to kind of slow it down, but it's going to deteriorate anyway. If you can help people to stay off alcohol, 25% stay as they are, the remaining 75%, I can't add up, will show some degree of improvement, some of which 25% will get a good, almost near normal degree of improvement. So it's something worth doing something about. And you get quite frustrated because you think, if I was standing here with a tablet telling you I could improve 75% of Alzheimer's cases, people would bite my hands off for it. All I'm saying is we need to help people get the alcohol safely removed from their body, which very often means a medically managed detox, in a unit that understands cognitive impairment, which is often an issue. You need to support them to stay off the alcohol. Now, in standard terms, that's counselling, relapse prevention medication, but you've got to adapt your counselling to somebody that's got cognitive impairment. You can't deliver counselling as usual. It's got to be adapted. As I say, support them to get proper calories in the right way, with a lot of healthy stuff, particularly their vitamins, rebuild their emotional lives, because they've often, because of stigma, burnt their bridges with their families. No family support, no friends support. You need to rebuild all of that, treat any mental health problems they've got, because loads of them have got anxiety, depression, other mental health problems. And sometimes, and as Raman said, mentioned with the patient he's dealing with, and I've got a number of patients that don't have capacity to decide A, whether they drink, or B, where they live. And we have to have a range of supportive accommodation of various different types, right from nursing homes down to care packages in their own home, that will help to support them to stay off. Now, what's really, really interesting with a lot of these patients is that, because, as Raman said, that stop button at the front of your brain that isn't working properly anymore, it means they drink in response to triggers. So if they're in an environment that triggers that this is where I have a drink, they're going to drink. Very often, when they're in a different environment, they're not pushing for alcohol. They're not saying, I want to get out and get a drink. They often settle very easily. And that is a really simple way of saving someone's brain and saving someone's life. Yet we don't do it so often.
Yeah, and I think it sounds like there's a really important message there in terms of, what you were saying about the 25%, 70%. There is, you can do, even if it's about stabilizing people and preventing deterioration, but also for that 75%, you're looking at improvement. And I think that's, perhaps a key message that everybody, needs to be aware of. I'm just thinking, Andrew, you were saying that you spend quite a lot of time, with people in recovery, and whether there's anything you would want to add here.
I think Julie makes a very sound point there about thiamine, vitamin B1, which is something that might be familiar to viewers of the old hospital drama ER, where it was always described as the banana bag, because this stuff is yellow and quite malodorous as well. But I know Julia and others have said to me over the years that when you're suffering with ARBD, you really can't get too much vitamin B into you, and it's one of the things that helps rebuild the brain. I mean, the other thing I would certainly make the case for is some kind of occupational therapy. I mean, Julia's hinted there about the living environment, but one of the ARBD stories I always remember is the one that Oliver Sacks used to tell in the 1970s, which is showing my age a little bit. But he used to talk about the man they called Jimmy the Lost Mariner, who was an American sailor who had ARBD, and he said that Jimmy recovered many of his functions when undertaking two activities, which were attending to the garden and attending mass. Jimmy was a Roman Catholic, obviously, so these will be different for different people, but these were purposeful activities that meant a lot to him, that he was able to undertake. And Dr. Sacks said that Jimmy was quite lucid when he was doing these things, and I think we need to look, as well as the medical and the pharmacological side, we need to look at those aspects of someone's humanity and their personality that they can recover, be it gardening or mass or bowling or whatever it might be.
So perhaps taking a strengths-based approach, where you're looking at areas of their lives which are good and you can build upon.
That's a very good way of putting it. I'd not thought of it like that, but yes, that's certainly what it is. Yes.
Yes, and I think I'm just complimenting what you mentioned, Andrew, that, Christopher Reeve, the old actor who got the spinal column sort of gone and then had paralysis, he was one of the, in my view, the pioneers who changed the way doctors or the medical profession thinks about neuronal plasticity, because with the recurrent stimulation and activities, he was almost able to rebuild the connections from the brain to the spinal cord to be able to do that, which takes us to the point of, the brain's plasticity to adapt and improve. So if we are looking at the nutritional, we are looking at side of things, if we make them that remits of neuro rehab, where you are purposefully making activities designed to tailor to that individual's needs, then the brain has a chance to improve and recover.
Yeah. So, I mean, it sounds from everything that everybody's been saying, that it is important. There are things which we can do. It's important that we look at these both in terms of recognising and actually intervening and ongoing support. Now that probably requires quite a coordinated effort to get that to happen. So I'm just wondering what advice all of you would give to policymakers and politicians about what needs to happen in terms of maybe managing, responding to ARBD. And I'll probably ask everybody on this one, I think. So if I start with Gareth, just what would be your starter for 10 on what we need to be sort of saying to policymakers and politicians?
Well, there needs to be an awareness of it to begin with, to raise awareness of ARBD, and then that needs to feed into joined up thinking. So there needs to be clear ideas of how interventions should be offered and what the pathways for those interventions should be. So that would be my starter for 10.
Okay. What about yourself, Julia? What would be your message to politicians?
I mean, I think the really important point that Gareth made is it's a pathway. You're not going to set up a dirty little service with 1 doctor, 2 nurses and a support worker, and it's going to deal with everything from ARBD. I mean, I run an ARBD clinic, and I get asked to do things all the time that is not my specialism, but it's attached to ARBD, and I have nobody else to call on. So it's a pathway, it's a multidisciplinary pathway, and it has to work properly. One of the difficulties we have is when policymakers, and you understand why this is the case, because they are keepers of the public purse at the end of the day, but they want to know the size of the problem. And as Gareth already mentioned, we don't know. And this, I think, to my mind, has been one of the biggest blocks that we've had to getting anything policy-wise. Now, what may help us is that the Joint Departments of Health and Public Health are currently putting together a set of national guidelines for the management of alcohol misuse across the UK. We've had guidelines for the treatment of drug misuse for a number of years. Everybody calls them the Orange Guidelines, but we're going to get some for alcohol. And within that, there is a section on ARBD. Now, I'm honoured to be chairing the group that's writing that bit, but that section is saying exactly this. And we've got the absolute guru of ARBD, Professor Kenneth Wilson, as part of that group. So, if Ken says it's law, because he is God. And this whole bit about it's a comprehensive package of care will be stressed massively in that section. And so you can't, as old age psychiatry, memory services, say it's not our bag. Yeah, it's partly your bag. You can't, as a care home for young brain injured adults, say it's not our bag. Yes, it is. It's partly your bag. And OTs and physios and psychologists and and everybody. So there has to be an acknowledgement that you're not going to make little services. They're going to trot off and sort it all out for you.
Okay, so it's about having that focus, but also the links and the coordination and a sort of a network there. Bev, what about you? What would be your thoughts about what politicians, policymakers need to take on board?
Well, absolutely what they've both just said. Definitely. I think just I suppose repeating in some ways, but one of the issues around thinking is clearly it's a bit of one of these catch-22 sort of situations, really, in that there is a lack of awareness. There's a lack of understanding in terms of prevalence, and sure, one of the first things commissioners want to know is, well, how big is the problem before they start throwing money at things. But also there just seem to be so many points potentially of contact for potential patients, service users, and or their families, friends, people who care about them, at different points across the sort of the broad spectrum of services and different settings. So having some sort of way of identifying, for the people who are the first points of contact, if you like. So one of the things we're trying to do at the moment, we've got a bit of research ongoing around sort of developing some sort of brief screening assessment that's not, I mean, it's a complex, very complex area, but in terms of just giving sort of frontline, you know, care workers, key workers, you know, whatever, just a light bulb moment, if you like, that this person in front of me obviously needs specialist assessment, at least to see if they need help and are on the spectrum of conditions. And I think if we can get policymakers to sort of understand a bit about the sort of resources in terms of, you know, awareness training at that very broad base level, often with lots of complex conditions, we need the people at the very base of that in terms of who people come into contact with first. And I think that's an area that policymakers should be, you know, public health should be thinking about as well. You know, it's important that everybody knows about this.
Okay, so it's about raising awareness, not just, I suppose, generally, but also specifically within those individuals, whether they're health, social care professionals who might have that contact, who might be able to ask the questions and start things happening.
Yeah, it's almost like a sort of, again, you know, back to some sort of traffic light thing, but just if people can flag up because of the potential for recovery and helping people, you know, I mean, obviously it's important to intervene as early as possible in any condition, but when it's something that has the potential, you know, before people tip into that 25% where they're just not going to get any worse, and even that is better than just leaving them to actually, you know, end up dying of this, then I think it's absolutely crucial. And, you know, the awareness needs to extend to policymakers and, you know, people in that position as well, doesn't it? Because obviously they can't be experts on everything, but, you know, so it's up to us to get that message across, I think.
Okay. Raman, is there anything you would want to add to messages to politicians and policymakers?
I think I want to just re-emphasize what you all have already said. Having a central database is very, very crucial, and how we develop that would have to be from the various, you know, coding systems that are used. And, you know, people coming in for alcohol problems we need to start looking at how do we code them. Is it from the A&E? Is it from the gastro clinics? Is it from the trauma centers? Now, I started doing a little bit of digging about this because of my interest in traumatic, you know, or the brain injuries. Now, there is a huge national database for trauma and orthopedics right across the UK, not just Wales, where all head injuries or brain injuries are recorded as such. And interesting discussion I had with one of the orthopods was what happens to those people who've had those brain injuries because of whatever causes. I think number one causes is road traffic accidents and alcohol. Well, they are treated, but then they are off in the community. Where are they? Who sees them? What is the psychiatric burden of all of those people? We don't have that. So I think a triangulation of all of that data from various sources is very, very important to build a case that we need specialist ARBD services, and we can't just you know, borrow from Tom and give to Peter to, you know, run you know, some of these services. And the additional thing is regarding training, and I think Bev has already put that across. The training needs to happen for right across the patch. And one of two big challenges that I come across in this part of this work is people tend to be afraid of doing a proper cognitive assessment. They rely very heavily on just screening tools, which may or may not give us much detail. So we do need to train people up to doing good comprehensive you know, cognitive assessments, and some sense of basic neurosciences, neuroradiology. So, you know, trainees, colleagues are gradually gravitating and asking me to interpret their brain scans for them, which, well, fortunately I've developed that skill over the years. So I started doing some talks on basic you know, neuroradiology. But those kind of things would be very helpful for the vast trainees, consultants, other colleagues to actually start looking at some of those brains that you're treating your patients, so at least you can see that brain and what are you actually looking at. And that I find very useful, because you can sometimes show the films to the patients themselves that, look, this is what your brain looks like. And if we can do something, it may change. And that is sometimes a light bulb moment for people that, oh, okay. And then some positive behavioral change begins to happen.
Okay, so training is really important, and making sure that the right people get the right training to be able to take this forward. So finally, Andrew, is there anything you would add to?
I don't think I've got a great deal to add there. I think, as Julie said, the message to people in the caring professions and to commissioners and service planners is that this is your bag. It might not look like it, and it might not be a very appealing bag sometimes, but it certainly is yours.
Okay. So I think we're probably coming towards the end of the discussion now, and I think it's been really interesting for me coming to this probably from outside of the area. And I suppose there's a few key messages that have come through. I think that the one that you've just made there, Andrew, about it's everyone's bag, I think is an important one for us to remember. I think the bit about the potential for recovery, the fact that either we can either stabilise or we can recover, but for that to happen, there's got to be this awareness, I suppose, at a number of different levels, at an individual level, at a service and professional level, at a policy level, and also at the societal level, because I think a number of you commented upon sort of societal influences here. And the fact that there needs to be, if you want good coordination, yes, we need specialist services, but that's part of the jigsaw. It needs to coordinate with other areas. So I'm just, I say we're coming towards the end, and I just wanted to give everybody just a 2 minutes if there's anything which you haven't had the chance to sort of raise. I'll start with Julia. Is there anything that you would want to add to the discussion before we end?
I would just say, anybody that's listening, think about how much you drink. Think about how much you got upset with lockdown that you couldn't go to the pub. Think about what it would be like to go 2 weeks without drinking and whether that would annoy you. It does us good just to have a little reflection now and then about our favourite drug.
Thanks, Bev.
Yeah, I would very much echo what Julia's just said there. And, I mean, we're all very good at kidding ourselves, but, on this one, don't kid yourself. We know that, GPs, if the GP asks you how much you drink, we know that they double whatever you said, it's like a standard thing, but you don't do that to yourself, because you're only fooling yourself. And just be honest, because 35 units a week is not actually that much to a lot of people.
Yeah. Andrew, is there anything you would want to add?
I mean, I Julia makes a very good point about lockdown. I think a lot of the problems may have shifted from the pub to the home, which is always interesting in that you've lost that sort of natural break that the barman might provide or the landlord might provide. And it'll be interesting to see after this. It'd be interesting to see what our drinking habits look like, say, in a year's time, and whether some of that heavy home drinking has continued or whether it was just a blip.
Yeah. Raman, is there anything you would want to add?
I think I'll just like to add, as Julia had earlier mentioned, that think about alcohol, but also not just think about alcohol and your liver, but start thinking about alcohol and your brain. Okay.
Gareth?
Well, I think I'd like to big up Wales as my final comment. This has been identified as an issue in Wales, and we've got research going on. We've got excellent clinicians. We've got terrific policy advisors. Don't want to embarrass anybody who's on this particular call. And we're in the position to be able to respond to this as a public health issue. So when policymakers sit up and listen, we're in the position to do something about it and be leading the way on it.
Okay, well, thank you everybody for a really interesting and informative discussion. I think you've clearly shown why raising awareness around ARBD is important. and I hope that everybody listening in takes away the key messages that you've so clearly put across. So thank you, everyone.
Thank you.